Hi dear students, this is Dr. Deepika Tikoo, your NEET PG educator for pharmacology, and today we are going to discuss the important image advantage series. So what we're going to cover in this is all the must know or the high yield images which are expected to come in your examinations. They have been asked previously and they can be asked in any form in future as well. So let's get started. So the first image here that you see is which of the following parameter is used to assess the rate of absorption. So what you're given here is a graph, and here there are certain variables present and you have to identify which of them is going to assess the rate of absorption. So your options are Tmax, Cmax, half-life and area under curve. All right. So let's see this graph, and before we come to this question, I will show you another graph here. So in this graph over here, we see there are two formulations, formulation A and formulation B, and both have been plotted. And this is your plasma concentration versus time graph. So here you see it is the Cmax for formulation A. And here you see this is the Cmax for formulation B. So Cmax, it indicates the maximum concentration that has been achieved in the plasma. Now, in how much time has this maximum concentration being achieved? That is reflected by Tmax. So this is the time here. So this one is the Tmax for formulation A. And if you see here, this is the Tmax for formulation B. So we can say Tmax for formulation A is around 2 hours, while for formulation B is around 5 hours. So this means that the time achieved or time taken to achieve this maximum concentration is less for formulation A as compared to formulation B. That means the rate at which that drug or formulation has been absorbed into the circulation, that is much faster for formulation A. So this tells you about that speed, and in other terms we can say the rate of absorption of a drug. So Tmax actually depicts the rate of absorption of a drug. Cmax just tells you what is the maximum concentration of the drug. And let's come back to this here. And if we see the other terms here, what is half-life? So half-life is the time taken by the drug to reach its plasma concentration to half. So how much time the drug takes to reach 50% of its original plasma concentration. That is called as T-half. So it has nothing to do actually here with the rate of absorption. So Cmax, I told you, is just the maximum concentration achieved. While this is the time taken, how fast that maximum concentration is achieved. So therefore, this will tell you about that rate. And area under curve is the whole area that is covered here. So how much absorption has taken place? That is this area. So in other words, what we can say that it tells you about the extent of absorption. Right? So this tells you about the extent of the absorption. So the correct answer here for us is your Tmax, right? So these two are very important terms. Tmax tells you about the rate of absorption, while area under curve or AUC tells you about the extent of absorption. So these are the two questions that are asked as your MCQs. Now, there are certain important formulas also that you should be aware of. Though these days there is less tendency you actually to solve some problem-based or these numerical calculations, but yes, they can be asked in the form of these MCQs. So bioavailability is area under curve of a drug which is given by the oral route divided by area under curve of a drug which is given by the IV route multiplied by 100. So this answer would be in your percentage, right? So area under curve of IV, which is the standard. We know the bioavailability by the IV route is maximum, or we can say almost 100%, right? IV by the IV route. So area under curve of the oral, obviously there will be certain losses when you're giving by the oral route. It can be lost in the GIT. And the second important thing is that the first pass metabolism plays a important role. So whatever the area comes for oral, divide by IV into 100. So this becomes your formula for the bioavailability. Then we have VD is the volume of distribution, which depends on the amount, and the bioavailability divide by plasma concentration. Half-life 0.693 multiplied by volume of distribution divided by clearance. So you see here that half-life is inversely proportional to clearance. If more is the clearance, less will be the half-life of the drug. Now, then these two terms, loading dose, maintenance dose, has been asked many a times that which of the following depends on the volume of distribution. So if you see, there is just a trick to remember. Now, loading dose has D in its name, right? D here. So plasma concentration and plasma concentration, they are both in maintenance dose as well as in the loading dose, right? The only difference is which one will multiply volume of distribution and which one would multiply the clearance. So volume of distribution also has a D in its spelling. So loading mein D and volume of distribution also has D. So remember, loading dose depends on the volume of distribution. While if you talk about the maintenance has no D in that. So it will depend on the clearance. So clearance, maintenance depends upon the clearance, maintenance dose, and loading dose depends on the volume of distribution. So this is very important to know. It has been asked many a times. All right, let's move on to the next question. Now, if you see a 55-year-old male with a history of chronic stable angina. So let's keep highlighting what are the important points in every question. So this patient has a chronic and stable angina. Visits the clinic complaining of frequent chest pain episodes despite taking his prescribed oral medications. The physician decides to switch one of his medications to the below given route to ensure a steady state release or a steady release of the drug, and this would improve the compliance of the patient. Now, which drug is most likely prescribed in a transdermal patch? So they have shown you that this is an example of a transdermal patch, a TTS. So can you tell which drug which is prescribed for chronic stable angina is available as a transdermal formulation or transdermal patch? So whether it is nitroglycerin, aspirin, atorvastatin, and clopidogrel. So if you do not know the answers, we can rule out the answers. We can also reach an MCQ to the correct option if you don't know the correct option. So we can start by ruling out the incorrect options if you know. So let's see clopidogrel and aspirin. These are two drugs which actually they are both antiplatelets, right? So antiplatelets, right? So these are usually given in cases of, let's say, there has been a suspected a patient has a myocardial infarction or a stroke. So these antiplatelets drugs are usually prescribed there, right? Then they are not available as a transdermal patch yet. Atorvastatin is a drug which is a hypolipidemic drug, right? It's a hypolipidemic drug, and it is used when there is excessive or increase in the cholesterol formation in the body. So again, we don't have any transdermal patch. Now, that leaves us with just one option, and that is your nitroglycerin. And yes, nitroglycerin is available as a patch. So patient or to prevent any further future attacks of angina, you can give patients a transdermal patch. So this is the correct answer, that is nitroglycerin patch. Now, if this question is there, definitely you can expect that a question on some other transdermal preparation can be asked. So let's go if there's some other transdermal preparations available. Yes, there are many, and you should be aware of these transdermal preparations. So what are these preparations? Let's go them one by one. Clonidine. So clonidine is available, and this is for hypertension. Important thing about clonidine here is that if you stop giving the drug, the major problem with clonidine is there is a rebound hypertension. So this is again has been asked many a times. So clonidine is given for hypertension, but if a patient misses a dose of clonidine, there can be a rebound hypertension, right? And that can land a patient into emergency. Fentanyl is an opioid which is given for chronic pain, like cancer pain for patients. So it can be given in such. Nicotine is given for smoking cessation. So if a patient, you need to wean off a patient, patient has to leave smoking, there you can give nicotine. Rotigotine has been asked. It is a patch available for management of Parkinsonism. Rivastigmine for Alzheimer's disease, hyoscine for motion sickness, nitrates, we just did, nitroglycerin for chronic angina, estrogen as a post-menopausal HRT, selegiline, depression, and oxybutynine for overactive bladder. So make sure you know the list of these drugs which are available as patches and what are their indications. Now, let's go to the next one, which is how you are going to identify the type of antagonism. So this graph is shown. It has been asked in one of the previous year papers, and this graph was shown and the student was asked to identify. Obviously, there were options given. So now I'm giving it as a open-end question. So which is this type of antagonism? So the antagonism, if you see, there can be like two types of antagonism. This is, and you have to identify. So let's say this is an agonist without any antagonist or without any added drug or antagonist, right? This is how the response is. So this is the maximum response that is achieved. So you know that one terms we should be very clear of, that the maximum response achieved. So we usually, the height, this tells you about the efficacy of a drug. So we can say that this drug has like a good efficacy here, while this, the dosage, the dosage tells you about the potency of a drug. So the height tells you about the efficacy. Height, which can you imagine which tower has the maximum height? Eiffel Tower, right? So Eiffel Tower, imagine this is the efficacy, Eiffel Tower, and the height will tell you about the efficacy. Potency is what the dose. If the less dose is required to produce a similar response or this response, the drug is said to be more potent. Okay, so potency. So if there is shifting towards the right, let's say this drug, so this is the drug, let's say. Now this drug A and this is the drug, let's say B. Now both drugs A and B, they have similar efficacy, right? Because the height is the same, they have similar efficacy, but you see the potency differs. So drug A produces the same response at a low dose, while drug B produces a similar response at a high dose. So definitely we can say that drug A is less potent, drug A is more potent than drug B. Why? Because less amount of drug A is required to produce the same response as drug B. So this is another important concept which is important here. Now, coming to the antagonism part, let us now come here. So this is the drug without any antagonist. Now let's say we give an antagonist and then we record a response. So the response is somewhat like this. So I have told you the terms potency and efficacy. So let's use the same terms, potency and efficacy. Now, after you have given the antagonist, so this was only agonist. Now this is agonist plus antagonist. So when you add an antagonist, what is happening to the efficacy of a drug? Efficacy is, height is same, so this is same. So they have similar efficacy. But what about the potency? Definitely the potency is going down. So there is decrease in the potency. So in other terms, when we talk about antagonist, we use two terms. One is called as Vmax and one is called as Km. So the maximum velocity here, that is the Vmax, and Km is the amount of the substance which is required to achieve that 50% of the Vmax. So here if you see Vmax or this here, this maximum, action. So when you give an antagonist, so this one, when you are giving, what is happening to the Vmax? It is remaining the same. But what is happening to the dose here? More dose is required. So Km has increased, right? So such type of antagonism where the Vmax remains same and the Km increases, this type of antagonism is called as competitive antagonism, right? That let's take the second scenario, right? The second scenario, what we have is again here, and let's take this drug. This is the drug or the agonist without any antagonist. And now we have added an antagonist. So now what is happening? This point, the starting point is remaining the same, and this is how the response is. So this is agonist plus antagonist. So here what is happening? The efficacy is going down, but this potency is remaining the same. And if we talk about this in terms of Vmax and Km, so what is happening here to the Vmax? Vmax decreases while Km, it is the same or unchanged. And such type of antagonism is called as non-competitive antagonism, right? So when there is a fall in the height, you call it as a non-competitive antagonism. When there's only shift towards the right, this is called as the competitive antagonism. Okay, isme there is fall, and in the competition, always you move ahead in competition, so you're moving towards the right. So if you see in this graph, what is happening? There is fall in the height. But here, the Km remains the same. So this is an example of a non-competitive antagonism. Now, this is one type of graph that you get. There is another type of graph sometimes they like to give you, and this is called as the Lineweaver-Berke plot. Only thing, you don't have to go into the details here. Just remember the shape of these graphs, and you have to identify the type of antagonism here. That is what is required here. So wherever you see this graph and you see there is a cross. Can you see here? There is a cross here. So cross starts with a C and competitives also starts with a C. So wherever there is a cross, you mark it as a competitive antagonism. Now this is the second or the third type of antagonism here is uncompetitive. So only how to identify it from a graph. So if there are two parallel lines running together and if you join them here, it is in the form of a U. So U stands for uncompetitive antagonism. Then if we see here in the third one, it is in the form of a V. So when we write N, little slanting here, so what this forms is, it forms a V. So this is a non-competitive. This is how you can identify these graphs based on their, the difference, how they look like. So this is a way to identify. This is what is asked in the exam. All right, moving on further. The given figure shows the effect of a drug on the blood pressure and heart rate. So can you now identify this graph, see the graph and tell us which drug is showing this effect? Whether it is epinephrine, norepinephrine, dopamine and isoprenoline. Again, what you have to do here is you have to see the effects of drug on the receptors. And the major receptors involved here would be your alpha 1, your beta 2 and your beta 1 receptors. So beta 1 present in the heart. So whenever they are stimulated, there will be increase in the heart rate. There will be increase in the force of contraction. It will cause increase in the cardiac output and it will cause increase in the systolic blood pressure. Now these are present in the blood vessels and they have the effect. So to remember the effect, you remember this mnemonic A, B, C, D. So alpha receptors, when they are stimulated, they cause vasoconstriction. Beta receptors, when they are stimulated, they cause vasodilatation. So constriction would mean increase in the blood pressure, that is the diastolic, while dilatation would mean decrease in the blood pressure. So if alpha receptors are stimulated, they cause increase in the diastolic blood pressure. Beta receptors, when stimulated, they call fall in the diastolic blood pressure. Now, keeping this in mind, we will study the graph. Okay, another thing before we go here, you remember, so whenever there is a fall in the diastolic blood pressure or the total peripheral resistance falls, the important phenomena is the baroreceptors, they come into play, and there is reflex tachycardia. Okay, that is important. Always remember this heart rate that is given to you here. It is the heart rate which, it is the reflex pulse. So always this will be opposite to that of the diastolic blood pressure. So this heart rate would be, let's say, opposite of diastolic blood pressure. So if you see the diastolic blood pressure falling, there would be reflex tachycardia. If you see the diastolic blood pressure rising, there will be reflex bradycardia. Remember that. All right. So here, if there is fall in DBP, there will be a reflex tachycardia. Now let's see how these drugs are going to function. So first drug you have with you is epinephrine. Now epinephrine, or the other name is adrenaline. Adrenaline starts with an A, that means it acts on all the receptors. So it will act on alpha 1, it will act on beta 1, it will act on beta 2. Beta 3 here is not relevant, but so here we say it acts on all the three receptors. Noradrenaline or norepinephrine, that means not all. So which not is there? So alpha 1, beta 1. It has no effect on beta 2. Dopamine has dose dependent effects. That first it affects the dopamine receptors. You go a little higher, it will act on the beta 2 receptors. Go a little higher, it will act on the alpha 1. So here in this, there is no dopamine effect being shown. So you can straight away cross out that option. Coming to isoprenaline. So isoprenaline, it is only active against the, or it acts on the beta receptors, beta 1, beta 2. So no alpha effect here. So let's have this in picture and now go to the graph. So if you see here, alpha 1 stimulation in epinephrine and beta 1 stimulation. So beta 1 is present here, beta 1 is present here. So both beta 1 stimulation we did, it causes what? It causes increase in the systolic blood pressure. Similarly, here beta 1, it also causes increase in the systolic. So what is happening in the graph? Increase systolic? Yes. So we have cut only one option here. The rest three are all causing increase in the systolic blood pressure. Let's go to the diastolic. Now, adrenaline acts on alpha 1 as well as beta 2. Okay? So alpha 1 is causing the vasoconstrictive effect. Beta 2 is causing the dilatory effect. But the beta 2 effect predominates as compared to the alpha 1. So there is vasodilatation and therefore there is decrease in the diastolic blood pressure. Noradrenaline has no effect on the beta 2, only alpha 1. So there is no way there is vasodilatation. There is only vasoconstriction and that will lead to increase in the diastolic blood pressure. Isoprenaline acts on the beta 2. Again, there will be a fall in the diastolic blood pressure, right? So the graph should go somewhere like this for this and this, while this would be like for norepinephrine. Now let's go back and see and compare. Now here the DBP is shown to rise. So which of the three has rise in DBP? That is noradrenaline. So यहाँ से we can rule out the other answers also. Isoprenaline, epinephrine. No longer true hold. So only there is increase in the SPP, increase in the DBP because of norepinephrine. So obviously the mean blood pressure will rise. I told you diastolic blood pressure, the opposite would be the action on the heart. So there will be reflex bradycardia here. So the correct answer here is your norepinephrine, right? All right, good. So let's move on to the next question. Yes. Now, this is another very, very important, often asked question. Which of the following drugs acts on the site 1 and 2? So here is site 1 and here you have your site 2. So the site 1 here, if you see closely, This is the receptor 5-HT1B and here it is 5-HT1D. So which of the following drugs acts on this side? Naproxen, Sumatriptan, Lasmiditan or Onabotulinum toxin. So here you first have to identify what is this condition, what are they asking about. So you will see where have you done drugs which act on 5-HT1B, 1D. Yes, these are the drugs. Here you see the CGRP is being released. There's vasodilatation. So can you think of the pathophysiology of disease which is actually happening here? Yes. So this is, they are talking about migraine. Right? And the drugs which act on 5-HT1B, 1D, which are used in the treatment of migraine, you have the drugs which are your triptans. Right? So can you identify triptan here? Yes, the triptan should, the name should end with the triptan. So the drug which we have here is your Sumatriptan. Now naproxen is also used in migraine, but it is not acting on 5-HT1B, 1D. It is a non-steroidal anti-inflammatory drug, so they are COX inhibitors. Lasmiditan is another drug which is used in migraine, but it only acts on the, actually on the 5-HT1F receptors, not on these receptors. Onabotulinum toxins, they actually are going to relieve the pain and they are going to act on the cholinergic system, but not here on the 5-HT1B1D. So the mechanism here is true for Sumatriptan. So this is your correct answer. So let's do quickly which are the drugs which are used in migraine, because this is a very important question often asked. So if you're asked to name the drugs, the drug of choice for acute attack of migraine, if it is just a mild to moderate attack, what will it be? They are your NSAIDs. But if it is a severe acute attack of migraine, then your drug of choice is triptans, right? Then it becomes your triptans. And then we have other drugs like lasmiditan. Now these drugs I told you, they act on 5-HT1F receptor, not on the 1D, 1B. And what is the advantage here with this is that jo triptans are there, they are going to cause vasoconstriction of the other vessels, blood vessels also, especially the coronary blood vessels, the peripheral vessels. So therefore you cannot give them in patients who already have let's say myocardial infarction or any ischemic heart disease, hypertension. We cannot give this. But lasmiditan, the advantage is it only acts on the 5-HT1F. So they are not present in the periphery. They don't cause any peripheral vasoconstriction. So they are safer in that case. Then we have the CGRP antagonists, or they are called as GPANTs, right? Those GPANTs, they are available for action on in the acute attack of migraine. So out of them, there is a drug called as Zavegepant, and this is available as also a nasal spray approved. So what is the advantage of nasal spray? So patient is vomiting, has nausea, can't take drug orally, so we can give them by a nasal spray. Then for prophylaxis of migraine, you remember this mnemonic ABCD. So what are the different drugs which can be given? So which are the drugs which can be given? These are your anti-epileptic drugs. So which are your anti-epileptic drugs? Basically, we have valproate, right? We have valproate, we have topiramate, and we have gabapentin, right? So one is this, and then we have B. B is beta blockers. B is your beta blockers and propranolol. This is the drug of choice for prophylaxis of migraine. To avoid any further attack or future attack, we give propranolol. C stands for, you have your calcium channel blockers, like you can have flunarizine, which is specifically used for migraine. And we have CGRP antagonists here also. But the difference is that these are monoclonal antibodies. So they can't be used for acute attack, they're given for prophylaxis. So monoclonal antibodies, which is your, one is erinumab, right? And then we have galcanezumab. Erinumab, Galcanezumab, and Fremanezumab. Right? So these are your monoclonal antibodies. So remember that the GPANTs are for acute attack and the monoclonal antibodies are for prophylaxis. And D, we can have the antidepressants. And like important example is amitriptyline. Right? So these are the drugs that are used for prophylaxis of migraine. Now moving on to the other disease condition, a 45-year-old female presents with progressive muscle weakness which worsens the activity and improves with rest. She complains of drooping eyelids, that is ptosis here, as you see here, and difficulty in keeping her eyes open by the end of the day. On examination, there is a bilateral ptosis and the patient has difficulty maintaining a prolonged upward gaze, which is a drug preferred for this condition. So this usually, or you can say this is depicting a condition which is called as Myasthenia gravis. Myasthenia gravis. So what is Myasthenia gravis? So Myasthenia gravis is a condition. So this is a condition where there is formation of autoantibodies. Antibodies in the body, they are formed against a specific type of receptor, and this receptor is your NM receptor. So these are present on the neuromuscular junction. So normally what happens, this is the cholinergic innervation here. So acetylcholine is released. It acts on the this NM receptor, and there is what happens there is it leads to contraction of the muscles. So when the antibodies are formed, these antibodies, if you see, they are blocking the receptor. So if acetylcholine now is released, there is no receptor for it to bind to. So obviously the contraction will suffer. There will be no contraction. So there will be relaxation. So gradually there will be paralysis. Especially it can get more serious if your respiratory muscles are involved because patient won't be able to breathe. So this is an autoimmune condition. Now what here you can do is, now let's say out of there were initially 10 receptors and 8 of them have been occupied by these autoantibodies. Now only 2 are left to be occupied. So for 2 you need you can do one thing, that you can keep acetylcholine there for a longer period of time, so that whatever receptors are available, at least acetylcholine can act on them. Now, problem with acetylcholine normally is that it gets metabolized very fast. In seconds, it will get metabolized. And how it gets metabolized? So, acetylcholine, it gets metabolized with the help of an enzyme, acetylcholine esterase. Very fast, in few milliseconds. Now, if you want to increase the concentration of acetylcholine here, you somehow need to block this enzyme. And we have now drugs which can block this enzyme. So they are called as anticholinesterases. So we give reversible anticholinesterases, right? So that is the main treatment for myasthenia gravis. So let's see, do we have a drug which is a reversible anticholinesterase in the option here? So we have physostigmine, neostigmine. Yes, both of them are reversible anticholinesterase. What about pilocarpine? Pilocarpine actually is a choline. This is a cholinomimetic or an alkaloid, and this is only available usually for topical use, and it is used in glaucoma, but it is topically applicable for as eye drops, right? So not specifically for, it is not used for myasthenia gravis as such. So we rule out this option. Atropine. Now atropine is an anticholinergic drug, right? And this will do the opposite. So already your NM receptors are blocked. So therefore atropine is going to further aggravate only. Okay? So atropine is not used here. Now we are left with two options, physostigmine and neostigmine. Now which one would you prefer? Now if you see this condition here, so we are involved in the they are involved in the muscle contraction. So the muscles, the peripheral muscles are involved here. Now if you give a drug, any of these drugs, let's say you give a reversible or any anticholinesterase, so if they act on this particular area, well and good, we are getting benefits, therapeutic effect. But what if this drug, let's say here you have your brain, right? And outside we have a blood-brain barrier. So what if this drug that you have given, apart from acting on this skeletal muscle junction, it also crosses into the brain? Then it will produce unnecessary effects which are not required, because the effects are required only in the periphery. So here what we are going to get are your adverse effects. Here what you're going to get is a therapeutic effect that is desired. So if we have drugs which are anticholinesterases, then we are further going to select those drugs which are specifically or preferably going to act in the periphery and not cross into the central nervous system to produce the side effects. So now next thing what we have to see is, out of the two options, which one of this crosses the blood-brain barrier and which one does not cross the blood-brain barrier. So we always know that the drugs which are highly lipid-soluble drugs, they can cross the blood-brain barrier, or drugs which are tertiary compounds, they can cross the blood-brain barrier. While bigger molecules, quaternary compounds, which are water-soluble, they cannot cross the blood-brain barrier. That's the rule here, right? So out of this, which is a tertiary compound, which is a quaternary compound? So physostigmine is a tertiary compound. Neostigmine is a quaternary compound. So which means this can cross the blood-brain barrier and will produce unwanted side effects. So we cross this, right? Here, what you have, your choice is now becoming neostigmine. Now, important thing here. We had crossed atropine here. Why we had crossed atropine? Alone, if you give atropine, then definitely there will be aggravation of the other symptoms, right? Now, atropine is also given along with the neostigmine, because what happens is that it will prevent the effects of neostigmine on the other area. So we only want effect on the neuromuscular junction, right? So, but sometimes what happens when you give neostigmine, what will it do? It will increase the effect of, or increase the levels of acetylcholine. And acetylcholine is non-specific in nature. It is non-specific in nature. It will act everywhere on the all types of the, it will act on the muscarinic receptor as well as on the nicotinic receptors. But atropine is usually it is a muscarinic. We call it as muscarinic blocker. So the action is desired on the nicotinic receptor. But when you give acetylcholine, it will affect both the receptors, muscarinic as well as the nicotinic. So nicotinic effect here will get us the good effects, but the muscarinic effect will get us the adverse effects, right? So to prevent the muscarinic adverse effects, to prevent this, what to do? We give a drug which blocks the muscarinic receptor. So when you give neostigmine, before you give neostigmine, you give atropine. So it should not be alone atropine. It is atropine plus neostigmine. That is ideally the preferred treatment. So when you give atropine, what will it do? It will block the muscarinic receptors beforehand. So when you give neostigmine, it is going to increase the levels of acetylcholine. Now, acetylcholine is non-specific. It can go to muscarinic receptor as well as nicotinic. But when it goes to muscarinic receptor, they're already blocked. It will not be able to produce any effect. It will go to the nicotinic receptor here in the neuromuscular junction, where the effect is actually desired. So you give atropine along with neostigmine. This can be another MCQ, that if the option is atropine plus neostigmine, then you will mark this as the correct option, because they are not given separately. Preferably, they are given together. So what are the other things, important things in myasthenia? So there is a diagnostic test, and this is also referred to as the tensilon test. So this is done with a very short acting drug which is called as edrophonium, 2 milligram IV. This is very, very short acting, won't produce. So if you give edrophonium and there is improvement, that means there is myasthenia crisis. So there is a patient who has Suddenly who has, let's say, he was improving, he was doing fine, suddenly his condition has now gone down, or he's showing some weakness again. Now you want to see if the weakness is because of over treatment or under treatment. If you're giving more of the drug, that is causing excessive stimulation of this, which is causing the weakness, or you're giving less of the drug, which is not sufficient to overcome the effect. So if there is an improvement, that means it is myasthenia crisis. You need to increase the dose of the drug. But if there is worsening, because you're giving this anticholinesterase again, so if there is worsening, then this is called as cholinergic crisis. This is because of excessive drug that you're giving. So you're giving more of the drug, more there is stimulation, and that also leads to the weakness of the muscles when you're excessively stimulating the muscles. So that is causing the weakness. So here you need to decrease the dose. Here you need to increase the dose of the drug that you're giving. So we are giving cholinesterase inhibitors. So both of these drugs, cholinesterase inhibitors, they actually are the quaternary compounds are preferred. Then you have other options like immunosuppressants that you give, corticosteroids, azathioprine, etc., plasmapheresis, and all those. But mainly in pharmacology, they are asking you about this drug, right? And tensilon test has also been asked previously. All right, let's go to the next question. A 60-year-old male with a history of hypertension and chronic kidney disease. So there is hypertension and there is chronic kidney disease. Presents to the emergency department with sudden swelling of his lips, tongue, and mild difficulty in breathing. He denies any history of food allergies or insect bites. His vitals are stable and he is on amlodipine, lisinopril, and metformin. So there are 3 drugs on which he is currently on. Which of the following medications is the most likely cause of this patient's condition? Is it amlodipine? Is it lisinopril? Is it metformin? Is it aspirin? Now, what is this condition? There is swelling of the lips and the face, you can see. So this is typically a case which is depicting angioedema. Angioedema. Now, the question is most likely. There can be certain drugs which are also causing in rare cases, but which is most likely the drug or culprit of causing this angioedema that we have to mark. So out of them, outrightly what we rule out is metformin. Metformin is used for management of diabetes mellitus, right? It's a bigonide. So there's no way or it doesn't cause angioedema. Now, there can be cases of aspirin, amlodipine. So, amlodipine is a calcium channel blocker, dihydropyridine. Maybe in rare cases it has cause, but it's not a very common cause. Similarly, aspirin, antiplatelet COX inhibitor. There is no, actually it is not very common angioedema to be seen with aspirin. So the most common culprit for angioedema are your ACE inhibitors, and that is one of they end with the word pril. So this is your lisinopril. So any ACE inhibitor or even a ARB, angiotensin receptor blocker, tons, losartan, candesartan and all those drugs. They all have the tendency to cause angioedema. So angioedema most likely cause is either your ACE inhibitors here or they can be your ARBs, right? So this is the correct option here. Now, what are the important adverse effects of ACE inhibitors? Another very, very important question. So you remember the mnemonic, the drug, an ACE inhibitor, captopril, you know the spelling, you know the side effects. So captopril, C is for cough. So cough is dry brassy cough, very, very dry brassy cough. Many patients with leave this ACE inhibitor because of this. And in case there is a dry brassy cough, why it happens? Because there is increase in the level of bradykinin. That, see, even angioedema, the reason is usually the same. But this dry brassy cough is especially because of increase in the bradykinin levels. So if patient cannot tolerate this, then you have to substitute with the other drug, that is the ARBs. Then there is proteinuria, taste disturbance, orthostatic hypotension, especially with short-acting drugs like Captopril. These are absolutely contraindicated in pregnancy because they are teratogenic and they can lead to renal agenesis. Right? In the child, they can lead to renal agenesis. Then in patients of bilateral renal artery stenosis, they're absolutely contraindicated. Hyperkalemia. So they lead to hyperkalemia. So therefore, there should not be given, or very cautious use is advised if you are given with another drug which is causing hyperkalemia like spironolactone. Right? Spironolactone is a potassium-sparing diuretic often used in cases, and if there is ACE inhibitor also prescribed, you will have to keep on monitoring the potassium levels. Right? Low counts granulocytopenia. So here I want to also emphasize on one thing. All the drugs which act on the renin-angiotensin-aldosterone system, all of them will have hyperkalemia as their side effect, right? So whether it is renin inhibitor, whether it is your beta blockers, they act on the beta 1 cells and JD cells, whether it is your ACE inhibitors, whether it is your ARBs, or whether it is your aldosterone antagonist, spironolactone we are doing, they all will have hyperkalemia as a side effect because they're all going to inhibit the effect of aldosterone. Aldosterone causes otherwise sodium water retention and it throws away potassium. But when you're blocking this effect of aldosterone, there will be opposite effect. It will be retaining calcium because it is not retaining now sodium and water. All right, let's go to the next question here. A 55-year-old male patient or a patient with DVT, deep venous thrombosis, was started on anticoagulant therapy. 2 days later, he developed gangrene of the toes as shown in the image. So which of the following drugs is most likely to be implicated in this condition? See this condition here? It's like a purple color. So therefore, this is also called as purple toe syndrome. Purple toe syndrome. So there is necrosis of the skin here, and this is classically seen with the drug which is your warfarin. So remember here the question is they are asking about the anticoagulant. So option 1 and option 4 are in any ways they are not to be considered because they are not anticoagulant drugs, they are antiplatelet drugs. So they are not to be considered. So heparin and warfarin. Now heparin and warfarin are two anticoagulants here. Heparin causes a specific type of side effect which is called as heparin-induced thrombocytopenia. And it will develop after about 5 to 7 days. While warfarin, this purple toe syndrome, it develops within 5 days, first 5 days when there is a maximum tendency because of the procoagulant effect. Right? Procoagulant effect. You know, warfarin, it acts or it inhibits the vitamin K dependent factors. कौन से vitamin K dependent factors? Clotting factors. 2, 7, 9 and 10. Also protein C and S. Right? 2, 7, 9, 10 protein C and S. So this is the action of warfarin. So in warfarin, it leads to the purple toe syndrome, or there is this dermal skin necrosis which can occur because of this procoagulant effect, right? And heparin, it causes heparin-induced thrombocytopenia, but that is usually after a few days, 5 to 7 days. And what are the other complications which you can see with warfarin or any of these drugs, anticoagulant therapies? Bleeding or hemorrhage. So whenever there is overdose with warfarin, what to do? The antidote, specific antidote for warfarin, actually, this is vitamin K because it acts on the vitamin K dependent factors. It's going to inhibit them. So when there is overdose bleeding, you give vitamin K as an antidote. Now there is too much bleeding, diffuse hemorrhage, then you can also give fresh frozen plasma and the prothrombin complex. Okay? 4-factor prothrombin complex. These are the They are pretty expensive as such. So you can give fresh frozen plasma, right? You can give these clotting factors, but this becomes a little on the expensive side. Then other side effects are cutaneous gangrene and this purple toe syndrome that we see. So you see this picture and you outrightly mark warfarin as the correct answer. What is the antidote if there is a heparin overdosage? For heparin overdosage, the antidote is protamine sulfate. Right? Remember these two important antidotes. Now, next is a patient with chronic gout presents with recurrent episodes of arthritis and he was initiated on a therapy that acts on the step 1, right? So, after starting the treatment, patient showed significant symptomatic improvement and which drug was most likely prescribed. So, now let's say which of the drugs. So, this is step 1 here. And which of the following drugs acts on step 1? Now, can you identify the drug which is acting on the step 1 here? The options are probenecid, colchicine, diclofenac, and allopurinol. So, out of these, probenecid, colchicine, diclofenac, allopurinol. So, please find out that which are the drugs that are acting on this, right? Now, remember here. Now, let's do this. Purines. We form hypoxanthine to xanthine and uric acid. There's an enzyme which is xanthine oxidase enzyme. So xanthine oxidase enzyme is responsible for formation of uric acid. If you block this enzyme or inhibit this enzyme, what will happen is there will be decrease in the synthesis of uric acid. So the drugs which are blocking this, they are also called as uric acid synthesis inhibitor. So they inhibit the synthesis. The other end is that you are going to enhance the excretion of uric acid. So one, you are going to block the synthesis. The other way is to increase the excretion of uric acid from the kidney. So this transporter, uric acid transporter, it usually reabsorbs uric acid back. So if you block this transporter, if you block the reabsorption back, so there will be increase in the excretion of the uric acid from the urine. And these drugs, they are called as uricosuric drugs. Right? Now, there is a third group also available now, which is your uricase enzyme. So recombinant uricase enzymes. They are not present actually in the human, but in the birds, this enzyme is present, uricase, which converts uric acid into allantoin. What is the advantage here? Uric acid is not that much soluble, in the kidneys or in the urine, doesn't remove that easily. But allantoin is very water soluble. So if the conversion occurs into allantoin, it can be easily excreted from the kidneys. So what this uricase does, it is present in the birds. So it was found that it increases the conversion of uric acid into allantoin, and because being water soluble, it was easily eliminated from the kidneys. So we have drugs which increase which are uric acids or uricase. They are recombinant uricase enzyme which will increase the conversion of formation of allantoin from uric acid. Now let's see what are these drugs and then we'll come back to this question. So the drugs which are used in gout, acute attack. So there is plain inflammation, acute attack. What will you give? So the drugs of choice here, you have first, you will give NSAIDs. Anti-inflammatory drugs, NSAIDs, like indomethacin and all those you will give. Right? Now, in gout, please remember, we do not give aspirin. Low dose aspirin actually increases the uric acid level. So we do not give aspirin. Remember, so that is not indicated in gout. NSAIDs, then the other drug very specific for gout is colchicine. And if both of them don't work, then we go to the third line is glucocorticoids. Alright, so this is meant for acute attack. Chronic gout. So there you have to prevent the attacks of the gout. So as I said, the first group was uric acid synthesis inhibitors. And the two important drugs here we have are allopurinol and febuxostat. Then uricosurics, which are increasing the excretion of uric acid in the urine. So which are these drugs? You have your probenecid, right? This is one. Then we have sulfenpyrazole. Then we have lesinurad, and we have benzbromarone, right? Benzbromarone. So with uricosurics, one important precaution that patient has to take a lot of water. Otherwise, there is a tendency that there will be precipitation of these crystals because the uric acid is being excreted, or it will be precipitated there. So a lot of water intake is advised when the patient is taking this. And if there is renal failure or any cause, then these drugs should not be given except for benzbromarone. So benzbromarone is comparatively safer in renal failure. Okay, so it is safer. All the other drugs should not be given in renal failure. Then uricase enzyme recombinant, we have pegloticase. So it's a recombinant uric enzyme. In the birds, it is rasburicase from the birds, and recombinant uricase enzyme is pegloticase. So the question here was which of the drugs acts on this step. So these are the two drugs which acts on this step. So let's find from the options if we have it available. Yes. So this is your allopurinol. So the correct answer is allopurinol. Now, let's move on to this question. Is in the given figure, identify the site of action of vancomycin. Antimicrobial, another very important question. So this question, if you see closely here, so identify the site of action of vancomycin. So here, let me highlight it for you. This is site number 1. This is site number 2. This is site number 3, site number 4, site number 5. So which of these would be the site of action of vancomycin? So here the correct answer is, this is the site number 4. So यहाँ पे we will mark site number 4 as the correct option. So let's just do this in a little bit more detail. So this is this diagram again. So you see the drugs which are acting here. So this is what a cell wall. So this is the bacterial cell wall. So all these drugs are cell wall synthesis inhibitors. All these drugs are cell wall synthesis inhibitors. First is phosphomycin. It acts on the first step of formation of cell wall. Second step, we have cycloserine. Third step, we have bacitracin. Fourth step, we have vancomycin. And the last step, we have your beta-lactams. Now, the order in which they act, it is important to learn this because the same diagram can be given to you and you will be asked to identify what site. Now, this is from inside to outside, no? From inside the cell to outside the cell, this is the order. So, there's a mnemonic to make you learn this easier. First cycle, बाद में van, then Land Rover. So first means phosphomycin. Cycle means cycloserine. Bad means bacitracin. Van means vancomycin. And Land Rover means lactams, beta lactams. So this is from inside to outside. So remember and see in the exam that if they have asked you from outside to inside or inside to outside, because if they are asking you from outside to inside, then the sequence would change. This would remain the same, just you have to do it in the opposite direction. So phosphomycin, cycloserine, bacitracin, vancomycin, beta-lactam. Just remember the order in which they're acting, and these are the drugs acting on the cell wall synthesis. right? So fosfomycin is not much used currently. Basically, it is only used for management of UTI. Cycloserine you will find also in the management of MDR, TB. This is another topical drug that is being used. These two, vancomycin and beta-lactams. So vancomycin is acting on the second last step, just before the beta-lactams. So vancomycin, it binds to the terminal D-ALA group. So, then D-ALA is not going to cleave off. The step here, when the terminal D-ALA cleaves, tabhi jaake there is a interlinking or cross chain is being formed in the NAM and the NAG, and therefore the cell wall becomes strengthened. But if there is no such if D-ALA doesn't cleave off, then there is no way the strands are going to be formed. So this acts just before beta lactams. So there is an enzyme transglycolysed, right? And this acts on the glycosylase, silase. And this is transpeptidase. So these are the two different enzyme or steps where they act on. So they are going to inhibit this particular step. Another thing important, vancomycin, which is often being asked, is that what is the use of vancomycin, right? So where it is being actually used. So it is used orally for the management of pseudomembranous enterocolitis. Oral use, right? It is orally used in this case, and IV it is used for MRSA. So orally for pseudomembranous enterocolitis. So there is another drug which is currently the drug of choice is fidaxomicin. But in India, it's not as such available. So we prefer in India vancomycin, but otherwise overall it is fidaxomicin which is preferred. So orally for pseudomembranous enterocolitis, IV for MRSA. What is the most common side effect which is seen with vancomycin is a rash. And this is the kind of that rash that you see, maculopapular rash is there. And this condition is patient is becoming red. It is called as red man syndrome. So what happens in red man syndrome? There is a release of histamine. When you give very fast IV, when you give this drug by very fast IV infusion, so there is a release of histamine and the patient gets all red all over. That's why it's called as a red man syndrome. So what is the treatment that you start with or give a very slow infusion, and you can even beforehand you can give antihistaminic. That is how you can prevent this. But if you give it very slowly, then there is less chance of having this red man syndrome. All right, so we'll do this last question, which is, which of the following drugs acts on the drug marked by the red arrow? So if you see the red arrow, it is marking here SGLT2 inhibitor. So which of the following is the SGLT2 inhibitor? What is SGLT2? It is sodium glucose transporter type 2. So basically it is present on the proximal tubule in the kidneys. Its role is it is going to reabsorb sodium and glucose back into the body. But if there's a patient of diabetes, you don't want the glucose to come back into the body. You want glucose to go out through the urine itself. So if you block this SGLT2 transporter, the glucose will not come out or will not be absorbed in the body, and even the sodium is not going to be reabsorbed back into the body. So what is it doing? It is protecting against two. So one, it is effective in diabetes mellitus, and the other, currently it is being asked that it is also a drug which is reducing the mortality in heart failure patients, because it is reducing the sodium reabsorption back. So there's no water retention in these patients because the sodium is not there. So it is very good drug for diabetes, especially if there is a heart failure. These are very, very important and most very frequently asked drug these days. So the SGLT2 inhibitors, they usually are gliflozins. So they end with the word gliflozin. So this is your correct answer. So this is Actually, a list I prepared for which of the drugs are the antidiabetic and act which mechanism. So sulfonylureas and meglitinides, they work by the same mechanism of inhibiting the ATP sensitive potassium channels. GLP-1 agonist or glutides, like liraglutide, semaglutide, so they are going to augment the insulin dependent, glucose dependent, they increase the insulin secretion as such. Gliptins are your DPP4 inhibitors. Another very, very important and often asked drugs are your gliptins. They are going to inhibit the degradation of the GLP. So therefore, they'll increase the GLP. Ultimately, they're going to cause the same effect. Bigonides, metformin, they are the drug of choice for type 2 diabetes mellitus. So what they do is they stimulate the AMPK, inhibit the hepatic gluconeogenesis, peripheral. So they are basically insulin sensitizer. They sensitize the peripheral tissue to the effect of insulin. So they also are responsible. They cause weight loss in the patient. And so the drug of choice in the type 2 diabetes mellitus, as I said before. Then glitazones, thiazolidinediones, they act on the PPAR gamma. So again, they are going to increase the sensitivity of insulin. Alpha glucosidase inhibitors or the acarbose, they are going to act at the level of the intestine where they inhibit the breakdown of the polysaccharides into simpler forms. So when they don't break into simpler forms, they will not be absorbed. SGLT2, I told you right now, very, very important drugs, inhibit the glucose reabsorption from the kidneys. And pramlintide is an amylin analog, which is going to delay the gastric emptying. So with this, we finished with the image advantage series where I discussed the series of images, and make sure to go through them and revise them again, and wish you all the very best. Thank you so much.